Appropriations and Adjudication now reconvenes with discussions on the Fiscal Year 2017 budget proposal from the Guam Memorial Hospital Authority. I want to preface this budget hearing and future budget hearings with the fact that the government of Guam has currently an FY 2015 cumulative general fund deficit of about $120 million. Now more than ever, we all have to understand that increasing expenditures against potential declining or flat revenue levels may not be realistic. We may all have to come to that realization either now or at some time in the near future. Before us today, we have the Guam Memorial Hospital Authority. In last year's budget, we gave what we thought was the largest subsidy of $21 million as a subsidy. The governor, in his executive budget request, which was submitted in February, proposed a $25 million subsidy, and the budget submitted by GMH is requesting $45 million in subsidy. I also want to note, please confirm this, Peter John, take the mic. Hey, Mike. Just for the record, is your board sworn, and who's overseeing the hospital? At one point, the governor had organic authority over the hospital. Is he still? Is there a board or what?
During my, or what I know, sir, is that the governor did swear in the new board members that were confirmed by the legislature. We do have a meeting scheduled for later on this month to be able to meet with the board and to begin to engage them in the operations of the hospital.
So the budget request that you're making was not approved by a board. Was it approved by the governor before it was sent out?
Yes, sir. It was presented to the governor, and in his capacity as the acting board, he approved us to go ahead and submit the budget. Did
any of you make him aware of the fact that the subsidy that you were going to be asking for was $20 million more than what he had set forth in his executive budget?
Yes, sir.
He was aware of that?
Yes, sir.
And that would mean, Ms. Manglotnia, since you've prepared budgets before and had part in the fiscal team, you understand that that means that straight off the bat, what the governor submitted as a balanced budget in February is now off by $20 million because of the subsidy request that you submitted.
Well, there are needs of the hospital that we had identified during the HMAT meetings, and the hospital had subsequently submitted its budget after the budget was submitted back in January by the governor. So that is a few months later, and it's the budget that we submitted this year is, for next year is about $10 million more than the year before. But of course, it wasn't, we weren't fully funded of what the needs are of the hospital.
But the subsidy, unless I'm reading a document different from yours, the subsidy you're requesting from the government of Guam is $45 million, right?
That's correct, because we projected the operating income from the hospital at about 95.7. So the needs of the hospital is beyond what the hospital can generate because of the uncompensated care and the underpayment of the 3M. So of course the operating income is not going to be sufficient to cover the operation of the hospital.
I understand.
Yes.
And in your former capacity as Director of Administration, this would put you in a real interesting predicament with a budget straight off the top by one agency being $20 million more than was originally submitted by the governor in February. And this morning, I had Public Health and Social Services. Their request was, well, thankfully reduced. Not reduced, but the amount that they're requesting is only $8 million more than what was approved by the governor, though the documents that they had submitted to us showed that they were requesting almost $60 million more than what was requested by the governor. They clarified that I should never have received Exhibit A and B, and
Yes.
so they're not making that request, but they're still making $8 million, requesting $8 million more than what was in the February executive budget. And you're requesting $20 million more. So today we're throwing off the budget by $28 million, just today. I wouldn't even count the previous days or the days that are coming forward. And I just wanted to get that clear, that my understanding. But I'll let you do your presentation. Mr. Camacho.
Buenas tardes, Vice Speaker, and members of the Committee on Appropriations and Adjudication. My name is Peter John Camacho, Hospital Administrator and CEO of the Guam Memorial Hospital Authority. I am here with members of our hospital team to present our 2017 budget and respond to questions or clarifications you may have. Our total request for 2017 as submitted is $141,058,256. Our anticipated revenues are $95,700,000. The balance is $45,358,258, which will be partially addressed by the governor's request of $27,493,093. That includes $16,938,824 of Medicaid matching. The need for additional funding is caused by several important factors related to our patient-payer mix. According to the latest audit on the hospital, the self-pay category and 3Ms comprise the largest category of patients, 18% and 55% respectively. What this means for the hospital is that we have a significant shortage in terms of the revenues that we need to be able to provide the services that we are mandated to. We are doing what we can within the hospital. We'd like to make sure that you are aware that we are doing our due diligence with regards to cost containment, trying to see how we can maximize the resources that we have. But there is a cost to provide the services, and with the revenues that we receive, the monies that reimbursements we receive, there is a shortage. And the shortage needs to be somehow made up in order for us to continue to be able to provide the quality of care that we know we can. We just recently completed our triennial accreditation survey by the Joint Commission, and we were pleased that we were able to pass that. As a result of the process, we were invited by the lead surveyor to join the Joint Commission on this journey that they call becoming a high reliability organization. And that basically means that we will implement zero failure rates amongst all of our critical processes and maintain that for a significantly long period of time. That's going to cost money in terms of supplies, in terms of the staffing that we need, equipment that is also needed. And so it's important that we are able to provide for those needs. We have a wonderful group of individuals and professionals who work at the hospital. These individuals are committed. They come in on a daily basis to be able to provide care for not only the patients, but their families as well. We, the leadership of the hospital, are tasked with providing them the support that they need to be able to carry out their duties and responsibilities. We must do everything we can to be able to provide the care, the supplies and the materials that they need to be able to do their work. It is truly an honor for myself to be able to be with them, to have come back to them, and to be working with them again as we continue our mission to provide quality patient care in a safe environment. And as simple as that statement is, a lot of things go into that. Making sure we provide the appropriate resources, making sure that whether it be material or human, to provide that care. We have very committed partners. We have the Guam Memorial Hospital Volunteer Association, who have for many years provided assistance to the hospital. We have committed vendors who work with us to be able to provide us with the needs that we have for our patients. But at the same time, we also have a responsibility to make sure that we reimburse them for what they provide to us. And that, with the challenges that we have with regards to collections, can be a challenge to be able to get that back to them as well. The 2017 budget, I believe, reflects what we need to be able to continue our journey, and also to look into the issue, or to that invitation on a high reliability organization. I really believe that we can do that, and I'm committed to working with our staff and our community to be able to provide that for our community. Thank you.
Anybody else? Let's go back and try to get the sequence of events. In February, the governor submitted his executive budget request. And in that, he increased the subsidy from 21 to 25. With the extensions I granted the hospital for the preparation of its detailed budget, you were able to submit to the committee on May the 10th a budget wherein you've increased the subsidy that the governor asked for from 25 to 45. Sometime earlier this month, the governor submitted to the legislature a Omnibus Bill, which included borrowing authority to pay off your 30% surplus in vendor payables. Supposedly enough also to cover, well, no, I probably shouldn't suppose that. How are these three related to each other? Or are they related to each other? If you get one, will you need the other? And
Mr. Speaker, the request for this upcoming fiscal year is for the operational needs of the hospital for that period of time. The Omnibus Bill that you're referring to is an opportunity for the hospital to take a look at increasing our ability to become sustainable. One of the challenge, or many, one common thing that I've seen throughout my work experience in the government has been that the hospital is generally at the short end of the stick. We're consistently short, which is not necessarily any reflection on funding requests or appropriations, because it is my sincere belief that the executive branch and the legislative branch have done their share to try to provide the resources as best they could, taking into consideration the entire government picture. However, it's not enough, and we read audit reports, we hear people talking, we read editorials that the hospital should be adequately funded. And so the Omnibus Bill is that opportunity, I believe. It gives us a chance to, well, first of all, there's a wing there that is unsafe and needs to be brought down because it poses a risk. We've done our best. We've taken our people out of that building and put them into existing spaces, but that has meant that we have also given up spaces. Our cafeteria is now a lot smaller. We've put them into different areas in the hospital. Whether or not that is efficient needs to be determined as we move forward. But taking a look at opportunities to create centers of excellence that would be able to augment the services that we provide or provide additional services that we currently don't offer is an opportunity for the hospital to bring in additional revenues. And there are other initiatives that we're looking at that look to shift the focus of how we provide medical care from the traditional inpatient model into something that is more focused on an outpatient type of consideration treatment so that we can try to shorten the stay, but the reimbursement for that would be much better. Just this week we had a visit from Ms. Ruby Cruz, actually Dr. Rubette Harford, and she was in a discussion with us. She actually was asking, because we currently are reimbursed at TEFRA rates, she posed the question, why not consider DRGs? And she mentioned the fact that Puerto Rico is reimbursed on a DRG basis. And so that leads to things, I mean, for me at least, to say, okay, these are opportunities that we can take a look at to try to figure out how we can better ourselves. I mean, in terms of financial reimbursement, I think that's an appropriate thing that we should consider.
And that's not something that this body can do.
No, sir. But I'm just sharing with you that the Omnibus Bill, provides opportunities. Other opportunities have come along. In the instance of Dr. Harford, who has posed the question and has expressed a willingness to work with the hospital. She currently works out of Puerto Rico, so she has that experience to be able to guide us. And she came back to Guam because she's been asked to be part of a federal commission that looks at Medicare. And so she's visited us, and I believe she's also visited GRMC, to open that discussion with the hospital.
Again, I go back to my initial question. The three documents are not interrelated, and are they?
They are.
It just seems like there are three different things that are before us. All right, just even if we just take out the executive budget request as being too early. Was this budget that you are proposing to us for 2017 considered and as part of what was being looked forward to as we go forward, or is this mutually exclusive? This thing has to go through, and the omnibus or whatever else is done with it. That all of that has to.
Mr. Speaker, I understand the question, and I've also asked the question myself. One of the things that I wanted to make sure was that any requests on the Omnibus Bill we needed to make sure that we weren't duplicating it, so that that would be a way of making sure that we didn't have to go for that, a bigger pot of money. And in looking and reviewing at the different documents that I've seen related to the Omnibus Bill, there is not a duplication. They're meant to enhance services that we have, provide additional services that we currently don't have. So are they mutually exclusive? No. I mean, they're all related, but they're not, I would say they're not duplicates. We're not asking for something in this budget that will reappear in the omnibus budget.
And with this need for 45 for next year, why wasn't that considered in the omnibus, or why did you guys present it to them as, if we're going to be borrowing 30 to pay for this year's vendor payables, can you get us the 45 so that we have what everybody's been calling the cushion to get through next year without a crisis of calling us in the middle of the fiscal year to try to address it? This 45 wasn't.
It's not part of that, sir. The borrowing to address the vendor payables was to take care of our current obligations and to give us a little bit of cushion, as you stated, to be able to address, even now, as when we pay off we pay a vendor, they release those supplies to us, but behind that there's already other bill, because we continue to submit purchase orders. That happens all the time. And so as we go, even though we pay it down, we continue to incur additional costs because we continue to get supplies.
Which is the reason why I'm asking, why didn't we ask to borrow enough money to be able to pay down the 30, pay the ones that's behind it, and address next year's? Because this is a big pill to swallow, try to find $45 million in a budget that's already overly aggressive and balanced, and I use air quotes very, 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 very liberally, to find an additional $20 million just for this afternoon to deal with the problem that you're going to have in the next fiscal year. Was that discussed with your HMAT or whatever that group is that?
In my experiences with the HMAT, we are looking at initiatives to be able, as we move forward, and so I didn't bring it up, Mr. Speaker, and
in your discussions with the HMAT, did they ask how well your urgent care was doing? Was it performing as was initially designed? Has it helped with the ER? Has it helped reduce billables? Did you guys discuss that with them?
those discussions did take place. They asked questions like that.
And what did you report to them as to the viability and the productivity of the urgent care? I mean, it was tagged as, I mean, when we passed it, I mean, no offense to the, I mean, not wanting to put any words into the mouth of the author, but the sponsor, but it was supposed to be one of the first silver bullets, and I'm trying to figure out, was it the silver bullet, or did we shoot ourselves in the knee again, building something that is being underutilized, not being properly billed, and just an additional place where we may be billing, but we're not receiving in payable. Anybody?
I can answer that, Speaker. Yeah, the urgent care, I mean, the author here, the urgent care was set up to address decreasing the volume of visits that to the emergency room that were not considered emergencies. Now, in doing that, of course, it would save the non-payer visits, because those that are visiting the emergency room would not be covered under the emergency benefit, and as such, many patients are ending up paying for that, and they go in the self-pay category. Having the urgent care there allows us to shift those patients to the urgent care and hopefully get appropriately reimbursed. When this was set up, we had a contract negotiations with the providers, the insurance providers, with regards to what could be covered within the urgent care operations. And some of those coverage do not extend to urgent care visits. So we were challenged in setting the urgent care up with what could be covered under the urgent care benefit versus the emergency room benefit. So it's difficult to really run the urgent care operation and still keep within the benefit package of benefit plan of the member. I'll give you an example. And if you go through the urgent care and you get a CAT scan, you are basically responsible for that CAT scan because you went through the urgent care. And so as an urgent care, it's a visit under a $20 copayment or $15 copayment. Your visit is covered, what they call examination and management, but the procedures charged under the urgent care will not be paid by the insurance company because it's part of the deductible. In the emergency room, if they're properly considered emergency visits, they will be subject to a $50 copayment, whatever the contract calls for, and they would all be covered under that. So that's been the challenge in running the operation for the urgent.
Would the CAT scan be covered if it went to the emergency room?
Yes. Yes.
So we've shot ourselves in the foot. We move over to urgent care.
No.
And now they owe you a CAT scan that can't be covered because they went through that door as opposed to coming in the ER door.
Right. I mean,
if we hadn't put the urgent care door there, they could have come through the urgent care door. I mean, the emergency room door. They would have, their insurance, if they had insurance, would have at least covered it.
Well, again, subject to whether the visit is an emergency or just an urgent visit, because they still look at the emergency designation of the visit. So It has to be a true emergency before it can be fully covered. But in doing this, again, it was to relieve the inappropriate visits to the emergency room, decrease wait time, decrease inappropriate visits. And so we basically triage patients to the urgent care unit that do not necessarily need emergency services.
So has it saved you money or made you money?
I think it's appropriately serviced patients. So those that are coming to the ER that don't need urgent care don't have to wait 2 hours or 4 hours to be seen by, the emergency room doctor, and they're seen quickly in the urgent care. I mean, I can call our Ms. Rada to give a report on how it's done in the service for the patients, not necessarily from a financial standpoint,
Yeah,
but in the service.
And Doc, if I think it's an opportunity to once and for all clarify this issue, right? First thing we got to clarify here is that there's no two doors when you go to the hospital, to the urgent care, or to the emergency room. You go into the emergency room, you have a triage nurse or personnel that directs the patient, whether it's an emergency, you go to the emergency room, and then or if it's an urgent care, you go to urgent care. So I think that's one thing that has to be clarified, is that the patient doesn't go there and chooses which door to go into.
No, they're triaged by the nurse
That's right.
in the.
So if they go to the urgent care, and just like you were saying, you were explaining the if it was a CAT scan was ordered in an urgent care setting, and it's not covered by insurance because you won't, even if that person was an emergency room, still won't be covered because it wasn't an emergency situation. So I think that has to be clarified, because how you said it is that the hospital now is being stuck with that CAT scan bill.
No, it's shifted to the member responsibility, which becomes a self-pay.
That's right, because even if this person went to the emergency room and it was deemed by the insurance company that it was an emergency, they won't pay for it.
Right.
So that's the first clarification. But maybe, there was a report, the Vice Speaker had FOIA'd the report of the urgent care. Based on my review of it, you're in the black. You're in the black, and you're also not tapping the funds that the government is providing in terms of the subsidy. And so, just by looking at that, and maybe you can clarify as well, is that if perhaps you expand the services of urgent care, that's where you're really gonna see the benefits. And so, but maybe whoever prepared that report could explain that report that the Vice Speaker received, because that clearly shows that you are in the black.
Yes, Senator, on the urgent care charges for FY 2015, we billed $1.154 million, and of that we collected about $555,000. So when you look at the billing to collection ratio based on the hospital's payer mix, because of the contractual adjustments by the 3Ms and the discount, the 8% discount, and some of the uncovered benefit by the insurance companies, that's about how much the hospital is being reimbursed. So I believe it has alleviated the needs for the emergency room, which in the past they were all over the hallway. They're marked hallway 1, and Bell can explain that, and we have seen that.
But I don't know how it can be considered as being in the black, because in the report that you sent me, you could not tell me how much the operation cost. Because the report that was sent to me said, well, we don't know how much in supplies it took. We don't know how much in whatever because it's all part of the GMH.
Senator, I didn't say it's in the black. I'm just reporting.
No, I understand,
but the revenues that we generated from the urgent care. That's what we provided you.
No, I understand.
Yes.
You didn't say it, but it's been stated from here that it was in the black, and I'm just saying we can't say that, because to say like, oh yeah, I'm doing well. Well, yeah, mom's paying your mortgage and dad's paying your car bill, but I'm doing well. But the urgent care wasn't making any of those payments because it's still the Bank of Guam. So I'm just trying to ask, and the report, I think I wrote back to you guys that, I mean, it's hard to be able to try to figure out how well it's doing if it doesn't have its own invoices that says for the operations of urgent care, it took X number of dollars to buy supplies. You just said it was all part of the overall GMH bill.
Yes, because when the materials management, when they send out orders for the hospital, they don't classify it as an order for urgent care. So
urgent care should have been billed for that. So we know how much was used there.
And Benita, if I may, Mr. Chairman.
Yes, I'm trying to look at the report that was just given to me today, and we do have a breakdown of the urgent care, of the personnel that we spended and other expenditures, which is about $408,000 for FY15.
No, I understand. You were able to give me the cost of the doctors and the nurses that were in there,
Yes.
but the supplies was not. And I'm just saying, in order to be able to say whether or not it was running in the black or
Yes.
not, you would also have to report what the cost was for other things. You can't just say, Mommy's paying my power bill, Nino's paying my, and I'm in the black. You're not.
Yes, I think, Senator, what you were asking was the payable listing, and if you look at the urgent care expenditures, it's
The supply expenses.
Yeah, there is a listing, because what I have here is just the totals, but it is 400. Yeah, that 415 is the total that includes personnel costs. So that's what the total is showing.
The supplies being there was not a lot.
Yeah. So
But in the report that you sent me, that wasn't there. Was it?
I understand this was the report that was sent.
Those were there.
Yeah.
And the cover letter said that some of the cost was all part of the general.
The payables, I believe.
Yes.
Yes. I think maybe Jun can clarify, because he's the one that breaks down the costs.
Senator, because the urgent care is just one of the units that functions in the hospital, so they function like a nursing unit. So they draw from the inventory, they pick up supplies from the inventory, and the department is charged accordingly. When they buy to replenish the inventory. That's why there is no accounts payable for urgent cost itself. So it becomes part of the whole accounts payable.
I understand that it's part of the entire hospital.
Correct.
But I'm just saying, in order to be able to say that we billed as much as we
Yeah, this one.
expended, you'd have to include all the cost of the operation. Let's move on.
Yes.
Okay, Benita, you mentioned contractual adjustments. For those of us that aren't in the medical, what is a contractual adjustment, and what's the decision on how it's given and how much is given? Is it equal? Is there whatever?
No, it's different on every bill. I'll give you an example of what a contractual adjustment could look like. For example, you go to the hospital and you stay in the hospital for 5 days, and the bill is $10,000, and you bill to the 3 M's. What's covered is just $1,100 a day. So whatever the difference, that is written off as written off as contractual adjustment, because that is not, the hospital doesn't get paid for that. So that's what we consider as an underpayment for the 3Ms. And the underpayment of the 3Ms for FY15 was about $47 million, and that was about the same amount the year before. And that's one of the problems with the hospital. And, you know, if you're really going to try to understand the situation of the hospital, why it's in the state it's in as far as trying to be able to break even, is because of the payer mix. There's the 3Ms represent 55% in FY15. So if you know, the total amount that we billed, which is shown in the audit report, we billed about $88 million, but then, you know, we only collected it's so small, I cannot see.
It's 47.
No, the 47 is the contractual adjustment. But I need to look at my other document. But anyway, it's about, you know, little less than half of what we built is what we collected. And so that's an underpayment for the hospital. And then when you go to also the self-pay, there's last year the total showing on the audit in the back was 32, but with a timing difference, the actual is about 29. And then again, you know, we don't expect to collect that because historically the provision that for the allowance is about 19, so that's amount we don't get paid. So when you add the 3Ms of you know, 47 million plus the $20 million, $20 million of self-pay, that really impacts the hospital. And that's why although we built $159 million, we can't collect all of that because of the contractual adjustments and the provision for the self-pay, and also on the insurance companies. We had removed the 8% discount that the insurance had been receiving effective June 1st. And I know you were harping about the contract, the last hearing we had last year, the budget hearing. So we were able to have all 4 providers sign the contract the provider agreement, and you know, we worked with them for a couple of months. There was a lot of negotiation going back and forth, and you know, they were not agreeing to the 8%, but you know, they asked if we can restore it. I said, well, maybe we'll look at it, but you know, until such time that the hospital fees are really at a realistic rate, then maybe we'll consider that, and we'll see how this goes. And
did all 4 insurance companies sign the same contract?
Yes, I told each one of them that, you know, we only have one template, and as soon as one signs, that's it. You know, there's no more negotiating. We're done. And it took a couple of months. I mean, we had been working on it since February, and you know, finally by May, we had sent them a letter back in April 1st that we will terminate the 2006 payer agreement, thus eliminating the 8% discount that they had been taken. So they didn't really have.
Are there any other contractual adjustments in the contract besides the 8%?
No.
There's no early payment, no.
No. That's the discount, because that's the 8% discount they were taking for if they pay within 30 days. But we took that away.
Okay.
So you know, I mean, they got hit both sides, because we removed the discount and then we raised the rates. And when you look at the collection mix because you know, you have the payer mix, right? But when that's the billing mix, and then when you go to the payer mix, the insurance companies is about 43% they comprise 43% of the collection of the hospital in the patient receipts. So they're really the ones that are feeling the brunt of the increases. But the hospital needs to survive, and we need to do what we need to do in terms of increasing the fees, because we had been cited by the Office of Inspector General that the fees are so outdated, and I was told that if we didn't do something about that, it will jeopardize the hospital's receiving of future federal grants. And this I was told when I went to D.C. and met with the Office of Insular Affairs in trying to clear the audit of the OIG.
Was that order in writing? Or
No, it was just when we were meeting to go through the findings and what are we doing to correct those findings.
So was there any confirmation letter that pursuant to our discussion in Washington, D.C., I have increased the rates as per discussion? I'm just trying to figure out where this order came from and if there's any proof of the order.
No, it was in the audit report. In their report that, the hospital's rates are outdated, and, the recommended, the response from GMH is, they're going to address the fee increases, and so, in fact, I just received an email a week ago that they're going to be coming back, and they're going to look at what we have done so that they can clear the findings on the audit report from the OIG.
Speaker, can I just comment on the contractual adjustments in my
Please.
explanation? Contractual adjustment really speaks about allowable charges based on contract negotiations. So if you charge $1 and they accept $1 charge, a payment, then that will be, there's no contractual adjustment. It also could be federal mandates such as Medicare, Medicaid, and MIP, where they pay their own rates based on per diem. Whether you're a participating or non-participating provider, and that was one of the issues when we opened up urgent care, was if we were going to have the fee schedules of the hospital applied to patients that come through the urgent care, we may not be preferred providers. Under preferred provider, they pay 70% of what they feel is the allowable charges, is not necessarily what you charge. And then finally, that's why even if you have the three payers, you still have contractual adjustments there, because it's still the coordination of benefits. If the primary insurance is Medicare, the responsibility for the secondary insurance, which is a local insurance, is based on Medicare fee schedule, not necessarily on the private payer's fee schedule. So those make up those difference, and they call it contractual adjustments. I call it allowable charges based on, again, coordination of benefits, insurance created by the insurance industry.
And I also want to thank Peter John and Benita for the information of the public. Yesterday evening, both of them came to my office, and after hearing my rant on the radio about why they couldn't provide me with a transparency report, they came in with 13 months worth of transparency reports. And though it's stamped draft, and I'm not supposed to be able to depend on it, and I have some issues with it, at least there was an attempt to try to address it. All right? And so I just want to publicly acknowledge that there was effort to comply. And in looking at the transparency report and even the one-page response that you submitted to us, the receivables are huge.
You have to take into consideration, Senator, the contractual adjustment there, the provision You have to subtract. That's why we have that one page to show you the net, because in our honest effort in trying to give you, because we thought you wanted to look at what was the net receivable for the hospital. That's why we made that effort to provide you that one-page report to reflect the AR balance at that point in time, after removing the contractual adjustments and the provision. So that amount is showing $23 million, and that report. I'm sorry, I have to look. That report did not include the unbilled, which are billings in process. We took that out, and also it did not include the in-house patients that are still in the hospital. In the report that is provided in the transparency report, all those numbers are included in there. So sometimes it can be misleading, because the system recognizes all those as receivable, although it has not been processed yet.
I mean, just even from the one-page report, just
Yes.
for the insurance companies, the receivables of less than 180 days was about 600,000, but prior years was 15 million.
Those are the prior years that we're still, the board in 2014 are allowed to write off about 170 some million, because these are accounts dating way back and they're still being carried in the books. And that's one of the reasons why I need some, I'm trying to dedicate some staff to work on writing off those receivables, because they're still being carried, and technically, they're really uncollectible. But
you said the board approved writing off of over 100 million.
That's correct. But even
is that taken into account in this report?
That's in there. That 180 some, it's in there. It's part of the report. I mean, it's part of that balance. It's when you go down to the bottom. I think there's one line item there where there's about 135 million.
Not in the one
So
page.
it's probably in the transparency report. I'm trying to find.
Yeah. But though the board gave you authorization to write off, it still hasn't been written off?
Because those accounts, the staff, they need to identify those, and we are working with IT to see if they can, just do a program to just write off that massive amount. It's a lot of effort, and for our purpose, it's a matter of prioritizing the resources that we have. And if you remember, in FY15, for the first part of the quarter, we weren't billing for about 4 months because of the system conversion. And the staff resources was spent on trying to catch up on the billing and send it out on time, so that we don't lose out if we don't send out the bill within the 90-day period. So that's one of the challenges. So now that we're a little bit more caught up and our unbilled amount is manageable, we have, the staff are working on trying to clear the write-off, because that's also one of an audit finding.
That's really disconcerting, because it seems to me somebody, either you or the previous CEO, presented to the board a resolution to approve writing off 100 and...
So it was 178. It wasn't, yeah.
$178 million
Yes,
in bad debt, air quotes.
Yes.
That 178, you didn't delineate which ones?
That was one of
Which
the
ones
challenges,
had
actually, when we came in, because I had asked where is the list, and for a time period there, because that was from the previous my predecessor, and so I was asking the staff. I said, where is the list that that accounts for the the 178, and so they struggled in trying to find that amount. I mean, the total amount that comes to that 178 that was identified by my predecessor. But the board did approve to write off the 178, and like I said, these are accounts dating back to the 90s, early 2000. So, our goal is to clear the books and remove those hopefully before the end of the fiscal year, because that was an audit finding. But like I said, it's a matter of prioritizing which one is more important. Are we going to spend the staff resources to write off accounts that are hopeless, or shall we prioritize resources in trying to collect, try to send out the billing? So that's what we did.
Yeah, but my concern is that the board was presented with a resolution that says write off 178 million. If it wasn't clearly delineated, it's these
Yes, I understand.
450 accounts can be written off. You mean to tell me, who would have the authority to sit there and go, this is my cousin, let's write this one off. This is my pari, I'll write this one off. It would... but I'm a little concerned.
I think it had to do with the billing period. And June, you want to comment on that?
No, but I'm just trying to figure out.
It has to do with billing period from this billing period to this billing period. So,
Okay. Provide me with a copy of that resolution of how, because I'm trying to figure out who has the authority to write off these things.
Well, that is a dated listing, Senator. At the time, that was Alan was, I think, 2014. Before he left, he was not able to write it off. Be that as it may, as we go along, those numbers or accounts have been, as we work the AR, have changed. So, but it should be relatively easy. Anytime we can get the database, you just look at the old accounts, and we can get a detail. We should be able to get the detail.
Well, then that should have been made clear that it was all ARs post or pre-2010 or whatever. Yeah. Because it just sounded 178 was written off, and by whose authority, which ones are supposed to be written off? I mean, if it's dated, then all the ARs of 2010 or 2014 and earlier are all written off. But at least the board did that. I'm just hoping that there was no authority given to CFO, deputy CFOs, or whoever, or CEO to decide which ones to write off.
I think
this is a little this is a little clear, and it's making me breathe a little better.
Yeah, Senators, part of the challenge in trying to write off accounts like that massively is also there are some accounts that are dated but are on like payroll deductions. So that's why that was the challenge in trying to identify, to make sure that we don't write off accounts that are on payment plan.
Do you have any further? Go ahead. Michael. Give me a headache.
Okay. Benita, and maybe June, since you're here, I'm going to go back to my previous question earlier about the urgent care. Based on the report that you submitted, and it does have the expenditure, you have the expenditure breakdown. And so based on this report, you're showing that you're in the black. So, and if you're not, please, say so, because that's something we want to clear here.
If I can remember, are we spending like $400,000 a year for each year, correct? I don't have this in front of me.
We only had, this fiscal year will be the full year. Okay. FY15 wasn't a full year.
Okay,
I
understand.
just started.
And we're collecting like, I don't have it in front of me, like 300,000?
I have the one that was just provided today, and it had here year-to-date expenditure for urgent care of personnel at 204,000 and other expenditure of 204 715. So it's roughly about 409,000. That's
Yeah,
what
I don't
that
know.
was
I'm looking
provided.
at the one you sent to the Vice Speaker. That's the report.
Yeah, this, like I said, I'm just reading this report that was provided.
So maybe if that's if you can update the report you gave him to make
Yeah.
it clear, I think that's very important for this body to see. Because if it doesn't work, let's end it. Let's end the program. The intent there, we worked with the hospital at that time. And the intent there was to alleviate the need for alleviate the overcrowding of the ER, and also to help bring down the cost. Because when you service someone who's at the ER and it's not an emergency, you are you're spending more, for that person, because you're not going to be able to collect from, even if that person is insured, you won't be able to collect because they would deny that payment. So.
I know, Senator, that it has significantly helped the ER because the census and the ER dropped by about 3,000, and but then the outpatient went up because there's more people that are coming also. So during those hours that's open, but if it was open because it was to alleviate the ER, it has done its purpose. And I don't know if it was really intended to make money, because it was
No, it wasn't intended to make money.
It was intended to provide a service because of what was going on. When you go to the hospital in the ER, you have all those gurneys that have their hallway 1, 2, 3, all the way to I think 16, and it's kind of unsightly to see patients all in the hallway.
So if your census has dropped in the ER by 3,000, does that mean your cost now in the ER has gone down too? It's supposed to be, right? I mean, that's what...
Senator, not necessarily. We still have the volume of really critically ill patients. You cannot decrease the physician support and the staff support in the emergency room. When you're talking about costs, are we talking about costs as to the tests that are ordered from and that may result in loss to the hospital? Yeah, it's gone down when you talk about doing it in the urgent care versus doing it in the ER. But from a staffing support, and the ER still needs the 2-man support every shift because of the volume of critically ill patients. I mean, this was just to alleviate the inappropriate, to decrease the inappropriate visits that should be in urgent care, and also hopefully decrease the wait time for those that just want to get themselves checked for simple medical illness.
How about the ones that went to the new hospital? Because when they first opened, when their services were not fully at 100%, but when they first opened, they were at more of a capacity than they are today. What does that do for the...
It actually, and we looked at that. There was some initial decrease, but it's tapered off. The normal visits for the emergency room is about 100 a day. That's been the historical number. It's gone down to 70 to 80 a day now. But the acuity of the sick patients coming through the ER is still too high for basically to reduce the overhead there as far as staffing support. There's just no way to staff the ER with just one emergency room doctor. We double cover every shift, and sometimes triple cover. As we open up urgent care, we're spending money in urgent care, yet the ER doctor still has to be, the ER service still has to be supported with the same level of staff. That's where we try to balance out, when should we open up urgent care, because there's no reason to have an operation in urgent care when the ER still has to be triple covered or double covered because of the volume of sick people coming in.
So I'm just looking at this report that was given to me this morning, and the ER budget from last year, it was at $5.575 million, but we spent 5.9, and this year again we are on track to spend the same amount, about 5.9, based on the expenditure as of May 31st, and then projecting for the next 4 months.
Did I mishear? Is it 24 hours?
This is the ER.
No, urgent care.
It's not.
It's not?
It's not 24 hours. It's open during those critical periods to help alleviate the emergency room, and that was what was intended for the.
And what hours are those?
I don't have the hours. I think Bell is the one that is responsible.
Your mic.
They're open from 12 to 10, 12 noon to 10 at night on most days.
Again,
we're open from 12 to 10 Monday through Friday, and then we did pilot Saturday at one point in time, but then it wasn't making any census. We're not catching patients. So what we did for this month is pilot on a Sunday, and it seems to be picking up on a Sunday. So we would like to maybe in the future to expand it as well. And then also another thing is we're open on holidays when in most clinics are closed. So we are really helping ER, to see these patients that are supposed to go to the
I'll
clinic.
grant you that the holiday time may be great.
Mm-hmm.
All right? I'm still trying to figure out why you would be open from at noon to 6 in the evening. It would seem to me all the doctors' clinics would be open at that time.
Mm-hmm.
People who have insurance would be able to go to their doctor.
Mm-hmm.
Even if it was till 10 o'clock at night, if memory serves me right, they could go to the community health center in Dedido, right? Isn't there an hour? Aren't they open until
Only till 8.
8?
Yeah.
Whatever it is, I thought it was my understanding.
Mm-hmm.
Maybe again I misunderstood it, but I thought the urgent care was going to be open to make sure that when people couldn't go to their primary care doctor
Mm-hmm.
or their or to the health centers, that they would be able to go to urgent care rather than tax the emergency room.
Okay. When we look at the hours, we look at the census for emergency room, and then I had several meetings with the physicians on what is the best hour. And the best hour, the peak for them is like around noon that patients come in. So we open at noon. Actually, it starts peaking at around 11 o'clock, 10 to 11 o'clock. So when we just didn't open it just because that's our convenient hours, but we look at the census for emergency room, and then we had a meeting with the doctors and the nurses on what is the peak and how we can help them, with so that they're not going to be swarmed with patients during those hours.
But why don't you just tell them to go to the community health centers or to their doctor?
If I may answer the Senator.
We do, Senator, we do.
I mean,
Also, when they go to urgent care and they want a follow-up, they couldn't even get a follow-up appointment. So what we do when we see patients that are public health, we even give them like an appointment or tell them to follow up to decrease the visit. They couldn't even get an appointment, Senator. We try.
So yeah, and to clarify that further, this is really just about serving, the walk-ins that normally would have gone to the community centers, but because they're limited in their ability to take in walk-ins, they're ending up in their urgent care. So that hour from 12 to 10 captures those patients.
And there is anecdotal information where, in conversations with individuals, I was at the community health center, but I didn't want to wait. So they get up and they go, or, they look and they see if it looks crowded, then they won't. They'll go somewhere else.
And so after midnight, everybody goes into the ER between midnight and noon.
Correct. We look at those hours also, if we can open like further, after midnight. But when we look at the census is so slow during those hours. So kind of like there's no point in opening urgent care during those hours, and we only see like 3 patients. So we look at the peak wherein patients are mostly coming into the to urgent care. And also another thing about urgent care that patients want is they pay less. And if I may add also, if a patient comes in and a patient needs CT scan, we transfer them to ER. If it's a rule-out stroke, we transfer them to the ER because we know that this patient could be admitted as well. So, and there are some also services like, let's say, for example, when the ER is so packed that if a patient needs like a simple, or the hospital is so packed, if a patient needs like a regular blood transfusion for only 1 unit, we do accept them in urgent care as well to alleviate the crowding also in ER and the hospital.
Let me reread the statute creating it, because I really thought that it was going to be open to assist in the middle of the night, that people didn't want to go and get a Band-Aid or a cold in ER, that it was supposed to be addressed in urgent care at a lesser amount. But if we're closed, then you're still getting the panicked mother with her first child having a cold and thinking that the baby's going to die in ER.
Correct.
When all it needed was an urgent care.
Visit.
But urgent care wasn't open for that.
Correct.
So they personally incurred a emergency room charge, which they probably won't be able to pay, or a insurance, even if they were insured, it wouldn't be covered. It wouldn't be an insurance covered cost because it wasn't an emergency.
Correct.
So they're stuck with a bill for emergency room costs as opposed to what was supposed to be a lesser charge or cost in urgent care.
Yes, we understand that fact, but then the problem is, if we're going to do that, is it more efficient, like spending this much money when we're only seeing like 3 patients, hire like 2 RNs to work like during those hours and support staff, rather than let's look at and a physician as well, and rather than let's just put this patient in the ER because there's so little, like 3-4 patients that may be qualified or go to urgent care. So it's kind of like looking at the cost efficiency. We can do that, we can do that open 24 hours, but we're looking at the cost efficiency.
It doesn't
and the
necessarily
revenue.
have to be 24 hours. It just seemed to me that I thought that the intent was to be open when the clinics are not open, and to be open when the health centers are not open, so that they would have some place to go that besides the ER.
I remember you said that before, and we also look at it. That's why we came up to a conclusion like, let's just open at this peak hour. I mean, we might not have informed you, but I understand that. I do remember that you said that. But what we're saying now is the cost efficiency on how we can better spend what was allocated to us.
Any questions? Go ahead.
Thank you, Mr. Chairman. Good afternoon, GMH. I just wanted to kind of bring it back to the numbers affecting the hospital. So we're talking about the need for a $45 million subsidy now for this fiscal year in order to be able to meet the operating expenses of the hospital. Is that correct? Yes. So the $45 million, if we don't give you that, you're going to be operating at a loss again. Is that correct?
It would probably or likely translate, Senator, into not being able to provide some of the services, medications for the patients, things like that, supplies. So that to me would be one of the most immediate effects.
Right. The point I'm trying to get is, if you don't get your $45 million subsidy, you're probably going to fall behind in paying vendors again.
Yes, sir.
And so when we discuss, for example, the borrowing initiative to catch up to your payables that have accumulated, the reason why those payables have accumulated is because you have not been getting the subsidy necessary over the years to prevent them from accumulating. Is that correct?
I think it's more like a combination, Senator, because the hospital has been getting subsidies, but also because of the underpayment issue and then the non-payment issue from the patients that receive care at the hospital.
But if the subsidies were adequate over those years, you would not have been accumulating that balance of payables to the vendors.
I would say yes.
Okay. And the reason why it's important for us to establish this as a baseline to our conversation is, we have a lot of healthcare dollars floating around in the system through the 3Ms, through direct subsidies, but the one area that's constantly bleeding red ink is the Guam Memorial Hospital. And so what I've been talking about over the last, week or two now, is the fact that we cannot keep increasing our healthcare spending with tax dollars in all these other areas when we have a single area, the Guam Memorial Hospital, that's constantly the one area bleeding the red ink. And so, just to kind of put it into perspective, the 3Ms, for example, Medicaid, Medicare, and MIP. Medicare is the reimbursement rates, the contractual obligations, is set by the federal government. Is that correct?
Yes.
Now, Medicaid and MIP, are those set by the federal government as well?
If I'm not mistaken, the federal government has to approve the state plan.
The state plan for Medicaid?
Yes.
But MIP?
I believe is
as a local
set.
statute.
Right.
Right? And so what we've done with the 3Ms is we've tethered Medicaid and MIP to Medicare in terms of the contractual obligations that we have to pay with the money that we have in the system. But Medicare in and of itself, federally set, we can't really change that, paid us out in 2015 38%. And so we've kind of set ourselves up by having our state plan tethered to Medicare to kind of doom us into getting a very low payout ratio. And we've set ourselves up even worse with MIP being a local statute, tethering it to Medicare, because now we're all paying at a much lower payout ratio to GMH than it's going to be able to receive sustainably. And so what I was hoping a lot of my presentations would spur in terms of conversation is, why don't we begin moving away from tethering our reimbursement rates to Medicare? Medicaid will take some time because we have to renegotiate it, but MIP, we can probably begin working on that right away. And as we move away from tethering to Medicare, let's focus on the reimbursement rates for those areas that are specific to GMH. For example, emergency room services. We're really the only emergency room operation in town. I know the GRMC is very unreliable in their emergency room services. So if we increase the reimbursement rates for emergency room services and MIP, that would get more MIP dollars into GMH. If we increase the reimbursement rates for all those other services that are very unique to GMH because of the ability for the facility to provide a much more sophisticated level of care in MIP, then we'll be able to get more of those dollars to GMH. And the reason why I bring this up is when I evaluated how much healthcare dollars are floating around in the system under those two of the 3Ms, the Medicaid and MIP, particularly the Medicaid, in 2011, GMH got $16 million from Medicaid, about $17 million, 16.9. And our Medicaid spending in the government of Guam was $37 million. So you got roughly half of the Medicaid spending. Fast forward to 2015, and GMH got $17 million from Medicaid, the exact same amount practically that they got in 2011. But our government, through tax dollars and federal matching funds, spent $81 million on Medicaid. So that difference of $44 million went everywhere else except for GMH. And over the course of those 4 years, GMH has been accumulating over all those years operational losses that have resulted in us having this huge vendor payable that we're having to go in and bail out. Now, if we had reprioritized those healthcare dollars to make sure GMH was getting what it needed to get in order to cover its costs, we wouldn't have this huge payable that we're having to borrow to bail ourselves out of. And so, has GMH, or, I mean, we've had committees even formed to evaluate these financials and come up with solutions. Has anybody sat down and asked the question, why don't we amend the state plan? Have you guys evaluated the state plans in other community hospitals in the states to figure out if their reimbursement rates are as low or as poor as ours are? Because I just can't imagine other community hospitals with these kind of reimbursement rates in their Medicaid programs. How similar is our Medicaid reimbursement program to other state plans?
Senator, if you look at the audit report, it's gonna mention, we mentioned about the GMH's effort to for the TEFRA rebasing, and TEFRA rebasing essentially is going to change the rate of how GMH has been reimbursed by Medicare, because the base rate is 1998 at 1992 to 1994 costs, but it is very, very difficult to change to get an authorization for rebasing, because it's rarely granted and we really have to prove it. But GMH has been making that effort, and in addition, we have also requested for adjustments for certain respective years, and we were successful in FY 2015 to receive about $3.8 million in adjustment money for 2007 and 8 years, and plus a rebasing of the HEART project, we received an additional $500,000. And so the hospital has made efforts in trying to address the TEFRA rebasing, but that was an act by the U.S. Congress, and I just want to make clear that it's not the local legislature here.
Yeah, I very much understand. What I'm
Yes,
trying to clarify in this conversation is that TEFRA rebasing has to do with Medicare.
I understand.
And getting the TEFRA rebase is very difficult because we're basically asking the federal government to give us a green light, and it's really up to them. But Medicaid can be renegotiated, and our state plan can be revisited, and MIP is entirely on us.
Well,
And so why is it that we're spending $81 million in Medicaid, and I think it's another $8 million more in MIP, and we're not changing the reimbursement ratios in a way that's going to be favorable to the hospital?
May I just comment, Senator? Senator Nicholas? Yeah, I mean, we have talked about, revisiting the state plan so that we could be paid at cost, but or at a fee schedule that whether it's DRG or fee for service, we've looked at that, and that's going to require CMS approval. But what you're really talking about here is more than just amending the state plan. Some of our patients under Medicaid and MIP utilize the hospital because there are no other community services around. So when we charge $1,000 for a patient stay, that may actually be only $500, but because there's no home care support, there's no placement for patients, and so it will raise up a community involvement in what are the social issues that impact delivering care to the Medicaid and MIP population that may not necessarily be a justifiable, appropriate utilization of our healthcare dollars. So in that regard, then, we were talking basically being also as a community and as a citizen of this community, I don't think we should be paid 100% of what we charge for Medicaid patients, because there are some social issues that unfortunately affect those patient population. So in the ER, for instance, we shouldn't be paid 100% of what we charge for ER because they're Medicaid and MIP patients, because some of them utilize the ER inappropriately. And how do you bill the patients that are under Medicaid and MIP?
I think that would be. I mean, I can see where you're coming from, but to be taking that position to the point where we're having this kind of a problem, I think the problem is more pronounced than the abuse. I think the problem is that because we've tethered Medicaid and MIP to Medicare, and because Medicare reimburses so poorly with respect to the unique services GMH provides, particularly emergency room services and inpatient services, I think it's important for us to start thinking about whether or not we need to change the reimbursement rates for Medicaid and MIP on those particularly two unique areas to GMH. And the reason why doing that will benefit GMH in a unique way is because unless there's another inpatient operation in town, they're all going to GMH, and they're all incurring those losses at GMH, and GMH is not getting reimbursed at an elevated or a rate close to parity. So if we just do that one amendment, it'll get a lot more dollars into the hospital. And so the reason why I wanted to bring it up is because, GMH needs that subsidy. I don't disagree, because if we don't give it to you, we're going to rack up these vendor bills all over again, even if we borrow today. But the question becomes, how do we get you the subsidy? Do we increase taxes and trash fees and then dump additional dollars into the healthcare system? Or do we begin reprogramming existing healthcare dollars and making these kind of plan adjustments so that existing healthcare dollars are getting into the hospital in order to stop the bleeding? And I think that, not only is the revisiting of the state plan an option, but if MIP could be changed just legislatively, let's do that.
Senator, if I might just comment, and this is a comment on the efforts of the Department of Public Health and Social Services. Over the years, the Department of Public Health and Social Services has done a lot to be able to move individuals from the MIP program over to the Medicaid program to be able to utilize federal funds that are available to supplement that. Nonetheless, we still have, the issue of the Medicaid and the MIP patients, and having been at public health and at the hospital in both capacities, I see the concern, or my concern would be, we increase the reimbursement rate, means the Medicaid dollars and the MIP dollars run out a lot faster. It'll run out because, you're going to pay out more. And don't get me wrong, the paying out more, it would be appropriate, especially for the hospital, but it's going to bring it down a lot faster. And then so the issue then becomes more complicated, because now we're going to need to look at how are we going to continue to fund those two operations as the monies move out a lot faster. It's a challenge.
I see where you're coming from,
yes,
but the problem is that I think the ball is just way too lopsided to the disproportionately in GMH's, and it's causing GMH harm. And I'm saying what we need to do is we need to rebalance the way we're making all of our healthcare dollars flow through the system. Because and I have a chart here, and this just alarmed me when it was created. The green line is all the healthcare dollars that are being spent outside of GMH, and the red line is GMH's losses. And so GMH's losses have been consistent from 2010 to 2015. But the healthcare dollars that have been spent on the system have ballooned from 20 million to 80 million. And so the healthcare system is disproportionately spending outside of GMH, while GMH's losses continue to remain constant. And so what I'm saying is our healthcare dollars need to be reprogrammed into GMH in order to begin mitigating these losses. And I think that the hospital and public health and all the other players in the healthcare area need to sit down and figure out how can we renegotiate our state plan, what legislative changes we can make in MIP, because if you don't get that $20 million subsidy, we're not fixing the problem.
And I understand, your analysis and where you're coming from. What I worry about, or what I will worry about, is if we redirect those dollars over to GMH, which with more of an inpatient type setting, the outpatient dollars that are available are going to shrink. We already have challenges with private practitioners accepting patients because they don't get paid adequately. Payments are slow. There's a myriad of different issues related to that. And what I fear is that we will end up, because GMH is getting all of those dollars, then the perception is, well, then let GMH take care of all of it. And I don't know that from a clinical side, whether or not that's something that is safe in terms of patient care, because we're going to create a traffic jam at GMH, and trying to find
I heard that stated before, but there's a difference between preventive care and if someone gets hit by a car. No amount of preventive care would have prevented that person from going into GMH, getting admitted into the ER, having an inpatient stay at the hospital. And so there's all these different ways that costs impact the entire healthcare system. The only thing that's been consistent is the fact that GMH is the one that's taking $20 million in losses all these years. In 2011, we spent $37 million in Medicaid. In 2015, we spent $81 million. $44 million more, but GMH's losses did not go down. If preventive care was truly working its way through the system to help GMH at the end, all that additional preventive care spending should be showing a decline in the operating losses of the hospital. But the reason why we don't have that correlation is because the disconnect between preventive care and the emergency care and the inpatient care that GMH provides is the berth is just too wide. And so what I'm asking is for the healthcare professionals to reevaluate that, because I'm not against investing in preventive care at all, but I think that over-investing into preventive care while we are chronically under-investing in emergency care and inpatient care is creating this problem in our healthcare system that we've borrowed for over and over again, that we're going to borrow for again in the future unless you get your $45 million subsidy. And so the only place that I can find $20 million more is in the rebalancing of these existing healthcare dollars that we're committing, unless we go out and raise taxes and fees on our people. And that's just adding more trouble, because then you have all the different socioeconomic impacts of that, poorer diet. I mean, how does that help, preventive care when your taxes go up and you got to eat, more instant noodles? So it's a delicate balance, but I think the greatest imbalance is the operational losses that GMH is sustaining and the need for us to reprogram existing healthcare dollars into the system. So thank you, Mr. Chairman, for the opportunity.
Yeah, and I think it might help the listening public to understand that increase is, I think the best way to describe it is, I was told by Public Health 2 years ago, in 3 M's they paid GMH $28 million.
2 M's. They don't pay us Medicare.
Oh, all right, but anyway, you got $28 million, but the renal care centers received 31. That's where it's at. And that's the Medicare rate that they have to pay for renal care, which is, they cover everybody. So that's where the issue's at. I think you have.
May I just comment on that, Senator? I mean, again, another point to take out of that is the emphasis on outpatient care. And so whether it's bringing back the renal dialysis unit to the hospital, or having some transfusion, the chemotherapy, for instance. And right now we can't provide chemotherapy at the hospital, so we've lost the opportunity to provide that revenue at GMH. And if it's paid out at $20 million somewhere, we want to get that at GMH, and that's part of the centers of excellence that we're looking at.
But it goes back to try to figure out who made the decision 8 years ago, or was it earlier than that, to close down hemodialysis at GMH to only the inpatient. It had a big, because I've sat with a number of patients as they were being, hemodialysis people who were coming from outside many years ago. So, it's those kinds of money makers that were there and then were given away, and the proliferation throughout the island now of renal centers, because they know that they're making money. But I think your oversight chair has a good question that I should have asked, but he's going to.
Thank you, Mr. Chairman. On the Gov Guam appropriation request, the Gov Guam subsidy for this year, I think it's 21 or 20, about 22. 15.3 of that is from the pharmaceutical fund that is diverted to be used for GMH as a matching, the local match for Medicaid, and then the 6.4 is from the Healthy Futures Fund. So, how do you break down the 45 million? Is it because the governor's request?
No, so you subtract the governor's request from that, so the difference would be the additional amount that GMH needs, because the one from the governor's request, I think that's 27. Part of that includes the Medicaid matching, so we already recognize that as income under the operating, because that's billing, that's for services rendered. So that's not a subsidy. We don't consider that a subsidy.
I think what your chairman is asking is, in all previous years, there's been an amount from the general fund, an amount for how much is pharmaceutical, how much is Healthy Futures, how much is two other categories. But when you submitted your budget, you just put 45 and there was no breakdown.
Because you're going to give us the 45.
I guess you got the medicinal marijuana before any of us did.
So for this year, Benita, the direct subsidy is only about 10 million. That's the
Yes.
Even if it's 22 million that's
Yes.
in the budget, the direct is about 10 million. So that
Yeah.
45 is what you're saying now is going to be what is 10 million will be the 45 million direct subsidy?
Well, yeah, subtract the 10 million. So that would be the whatever the direct subsidy is for FY17 would be the difference would be what we need. So Senator Cruz, I'm sure, is going to look for that.
Okay, that's what I wanted to clarify then. Thank you.
Yes, thank you.
One of the issues, at least with the new hospital and your plans for Centers of Excellence, what is your current physician population at the hospital? I mean, how many doctors do you have? Are you fully staffed with all the doctors of the different hospitalists that you need?
We have most specialty service providers in-house. We've also been approached by other specialists that want to practice at GMH if the equipment and the resources are there. We have interventional radiology. We have cardiology that can do cardiac cath, but at this point, we don't have the cardiac cath facility.
You did, didn't you?
We actually can use the current, the interventional suite for both cardiology and what they call interventional radiology.
And do you have a doctor that's ready in the wings to come out. I'm just trying to figure out where you're finding your doctors that everybody else is having problems throughout the country trying to find doctors, and you have them lined up at the door waiting to get in.
Actually, yeah. I mean, I tell you, Senator, I got a John Hopkins graduate that came here as an internist, and basically Harvard graduate. They're coming here. They want to experience this part of the world. And I do have some great doctors at GMH. I'll introduce them on the public hearing on Monday.
No, I understand that there are excellent doctors there and excellent. I'm just trying to figure out, even if you got the doctors, is GMH blessed with an overabundance of nurses? Or, I mean, at one point in the past, we've had an inability to fill all the nurse vacancies. Do you also have a treasure trove of nurses that are ready to move to GMH?
Hi, Senator. We still have a shortage of critical care nurses. However, the University of Guam has been doing a great job in, providing us with new nurses, which we are able to train in our med-surg, our adult care areas. And as recently as a couple months ago, we actually have a champion doctor, Dr. Sablan, who was recruited to help in the ICU. So she has provided her services to actually train these new nurses. She wants to take these new nurses from the university to train them in critical care nursing. So this is really an opportunity for us. It's actually a first. It's really difficult for nurses that are very brand new to move into a critical care area.
No, I understand that, which is the reason why I was saying you don't have the critical care nurses.
Well, we will.
And do you have the nurses to assist in the cath lab and for open heart?
I think the uniqueness of GMH is that we do have nurses that are already trained in all the areas, because it's not just cardiac cath, but you have to ensure that you have nurses to take over post-operatively, right? Like in OR, in the telemetry units, and so forth. So in regards to the cath lab, Bell is ready and able to provide those nurses to assist in the cath lab, in addition to the technologists. And in the nursing areas, I can say confidently that we are ready to provide that service. Like I said, we're really unique in that we have that opportunity with our cath lab and with the assistance of Dr. Concepcion to train our staff. And they're still with us, so we haven't lost any of that specialty to the new hospital.
Go ahead, please.
Going back to the physicians that you have, some of them are on call, or they have a certain number of hours that are the doctors put on a retainer, so to speak, so that regardless of how many hours they work, they're compensated at a fixed amount. I'm looking at your tab 3 under medical, and I notice a whole list of physicians. So how are the physicians compensated in the hospital, those that have hospital privileges?
Well, we have two programs. One is the hospitalist program, and under the hospitalist program, the physicians are paid as full-time employees under a salary. Then we have those that take call and get a stipend for taking call. Part of our responsibility under the conditions of participation with Medicare is that we have an on-call physician identified. So, for instance, in the surgical specialty, we don't have surgical hospitalists. We have on-call surgeons. We're looking at being completely hospitalist-based, so that we can provide, basically more consistent care and have the readily available staff in-house.
So But the compensation for the budget that you set aside then for those positions is more or less fixed, or does it vary considerably, or?
It's fixed based. I mean, again, it's specialty based. So, for this year, we have a salary structure for hospitalists and internal medicine. The on-call compensation for the surgeons have been fixed for the last 3 or 4 years. My CFO is pretty strict with any pay raises.
And very consistent with overtime too. I know it's a difficult situation.
It's tough because I think you're looking at the emergency room and the ER. I mean, the emergency room and the intervention and the radiology are the 2 departments that we have a lot of overtime. And just because, unfortunately, I don't really have a full staff support yet.
Yeah, and I know your telemetry also has quite difficult schedules, as I recall.
Yeah.
The workload was quite difficult for them. Yeah, we sympathize with them, and they do a great job.
I knew that in my old age that I might have short-term memory issues about who and where I had lunch or what I had for lunch, but for a couple of years ago when we were creating this urgent care center, I thought I specifically remembered some stats. I mean, and it's in the findings for the creation of the legislation, but it says y legislatura en Guam finds that this disproportionately high percentage of services being provided by the Guam Memorial Hospital Authority emergency room are dedicated to non-emergency medical services as compared to normal dedicated emergency room services. Further, these non-emergency medical services are more costly to provide within the setting of an emergency room and should more appropriately be available through private medical clinic or by way of an urgent care center. Y legislatura Guam takes due note of the GMH report on emergency room utilization for 2010, during which 19,291 non-emergent cases exceeded the 8,785 actual emergent cases. Of the 28 million point seven in costs of going to the emergency room for 2010, 68% or 19.6 million was for non-emergent cases. That was in the legislation that created the urgent care. So I know that somewhere I remember that, and I'm just trying to figure out why we aren't doing our hours and to take care of that finding, which was very, very compelling. In 19,000 versus 8 and 28 million versus 19. Yeah, it's just... Anyway. And I still didn't vote for it because I knew I wasn't going to do it. So anyway, anybody down here? Go ahead.
Thank you, Mr. Chair. I really just, first of all, I just want to thank all of you, and I'm grateful I don't have to use your services. And secondly, you did mention during your testimony that you had some cost containment. You had some cost containment programs, or I just wrote, yeah. Can you describe what some of those are, and if you have some dollar amounts that had resulted from the cost containment?
I don't have that specific information on the dollar amounts, ma'am, but in terms of cost containment, we're looking at things like reducing the overtime, looking at other ways that we can try to save, monies that we need to expend. So it was generalization. But we can, if you'd like, we can try to get you that information. Yes?
Thank you.
If I may just add, Senator, on the cost containment, I don't have the numbers in front of me, but I would venture to guess that, the cost for delivering for that visits in the emergency room that translates to the amount that you're talking about is probably as decreased, because in the urgent care setting, you would not have ordered, CAT scans and other stuff because they're appropriately. Again, patients showing up to the emergency room under EMTALA, okay, they really need to be evaluated, and there's a greater risk of patients walking to the emergency room than those working through urgent care. So, there's unfortunately sometimes a practice of ordering almost everything that when a patient comes to the emergency room, not necessarily for the simple lacerations, but in people having some, medical illness. So, all the evaluation of patient emergency room is more expensive, as you know. So the cost containment is not ordering those tests that are not appropriate by shifting them to urgent care, and the urgent care has to serve that role.
Yes, and I understand that. And maybe I'll ask this question now on whether or not we have our electronic healthcare records, so that it would be clear that certain things aren't necessary if the patient went to their primary care provider rather than when going to the emergency room. Rather than having an urgent care center that's open at the same time that the doctor's clinics are open throughout the island, and open it when everybody else is closed, or like you do on the holidays, thankfully. And it may be lower, but that we were supposed to try to address those issues. And I'm still befuddled by that decision. But I know that Senator Morrison is Mr. IT, and if you showed him the stats on how the conversion was near impossible with 300,000 having corrections that had to be made, we might all go back to paper. But I'll let him ask his questions because I know he's very interested in your IT.
Actually, that's not my question. Thank you, Mr. Chair. Thank you. Thank you all for the presentation. Ms. Maglonia brought up the fact that we've been dealing with an outdated fee schedule, and I know that based on the reports on your website that it's the fee schedule was updated on April 1st, right? That's correct.
That's correct. We raised it 5%.
How much of a factor has that played in the overall issues of vendor payables and this vicious cycle?
The impact is not going to be felt immediately. Of course, that 5% increase, you have to think about the payer mix that, although we raised it 5%, when you apply the 5% to the Medicare, the 3Ms, it really has not a very big impact. It has a bigger impact in the insurance and also the self-pay. So with the projection that I had done, with the 5%, maybe the net realization on that is approximately 1.8 million. So it's not a significant amount, but that's the highest that we can go. So that's actually one of the reasons why we're looking at the other fees that have not been raised, and we're looking at the room and board. But we have to do our due diligence first to look at bundling the supplies in for the room and board, because that's one of the problems that we've seen also is they scrub the claims, and some of the supplies that are being used they deem it excessive, but it's for us, it's not. It is supposed to be part of the charges, but they would remove it, thinking, saying that that's standard for the room. But so we're looking at what is the standard supplies that should go with the room and board. So we will just bundle the room and board services. The room and board fee.
Thank you. The reason why I asked this question, because I think it's over time, knowing how outdated the fees have been, and it really compounds the problem over time. And I'm just and seeing that the industry and factoring inflation into the cost of the services or the pharmaceuticals or whatever that the hospital needs to operate, I'm just looking at the fee schedule and seeing how it's adjusted accordingly or periodically, so that we don't have this compounding issue over time. I remember you stating that the fees have been outdated for far over 30 years, right? Is that correct?
Well, some have been, since the 80s, 90s. So we are, we're making an effort now to review the fee schedule regularly, and actually we are again looking at some of those fees that have fallen below the Medicare rate, which the Medicare has posted their fees for 2015, and we have our consultant is we have given them the charge master for the hospital, so they're analyzing which of those fees have fallen below the Medicare rate, and also we're working together to look at the room and board.
Is there a policy in place to reevaluate these fees every 3 years?
No, there's a board resolution to adjust the fees 5% annually that was approved last year. And we had also, in our response to the Office of Inspector General, that we have a group in the hospital that is reviewing the fees regularly to ensure that it is adjusted. So we are working on that.
I'm glad that's taking place, because I'm concerned what took place with this legislature addressing this very, very outdated fee schedule.
One of the challenges that we have is, like, for example, it falls, some of the fees that have fallen below Medicare rate, and if we're going to bring it up to Medicare rate and it is above the 5%, we would have to, it's going to take a while for us to have to conduct our public hearing and then go through the AAA process to have it increase. Whereas if it falls below Medicare rate, we can just adjust it, as soon as the Medicare rates are published, and then we just notify all the stakeholders that, the hospital is going to be increasing it to Medicare rate.
Right, and I think if we reevaluate it every periodically, timely, understanding the demands or even the industry's changes in pricing, I think that will have a better, I guess, with the public, because what took place when we were adjusting the fees, obviously when you're dealing with some of the fees that are 20, 30 years old, it does shock a lot of our people in our public when we are making adjustments that are getting us caught up 20 years, 30 years later.
So I just want to say that I had the staff worked on a utilization based on the fee schedule that we had, those that was increased last year. The impact on that to the hospital is probably about half a million.
Okay. Thank you, Mr. Chair. Thank you.
I just want to make sure I understand. So this budget that's being presented is moving forward into 2017, and it's an underlying assumption is that the payables of $30 million will be taken care of by somebody else somehow.
That's correct.
That's the underlying assumption. Now, in the media, there's been a lot of discussion about there's this HMAT team that has come in Who are these guys? It sounds like they would have the silver bullet to come in and fix everything.
You're looking at one of them, Senator.
Okay, all right.
It's the governor had appointed certain members and from revenue and tax and Marie Benito and some not an IT person.
Yeah.
And Will Castro.
And what was their objective in being set up? I kind of got the impression that they were supposed to go in there and they were the ones that was going to turn the place upside down and then come up with solutions to put everything back in place.
Do you wanna?
When the governor assumed control of the hospital, sir, and saw the state that the hospital was in, my understanding is that he mobilized different resources within his cabinet to be able to come together and working with the hospital to be able to understand the problems and to make recommendations to move the hospital forward. And as I see the work that they've done, it's to ensure that the hospital is going to be able to stand on its own. And I think the hallmark of the work that has been done is the sustainability of the hospital. Minimize or eliminate the need to come down to the legislature or to a bank and say, we need to borrow something to be able to take care of something else, and looking at how we can, within the resources that are available to us internally, as well as what we can do to be able to move forward. That combination will allow us to be able to basically stand on our own 2 feet.
And I guess I raise that only because from what I've heard here in the past 2 hours, it seems like you guys have been able to really kind of take a look and come up with your own solutions. So I was just a little confused as to who this HMAT group is.
So sometimes, Senator, if I may, and I think it's the extra eyes, it's the extra mental capacity that comes in to be able to assist, organize or help the analysis, because sometimes when you're basically caught up with, trying to survive and having been at the hospital these different times, and I think especially when Senator Underwood was there, just trying to make sure that you survive on a daily basis, you don't necessarily have the time or the energy to be able to say, okay, so let me step back and let me take a look at the mess that we're in and how can we fix it, because the leadership, the governance are looking at how can we bring the resources there for the staff who are at the bedside taking care of the patients. It may not seem that complicated, but it really, for me, it is, because unfortunately, I don't feel that I'm a good multitasker. I will focus energies on things and then move accordingly. I envy people who can multitask, because I think that's a wonderful skill or a blessing to be able to do that. I unfortunately have not been blessed that way.
Okay.
But again, like I said, I've been there long enough to know that when we have to worry about making sure that we have the supplies for the patients, we have the medications for the patients, when we have the staffing for the patients, and who do we turn to, and especially when outside help is also limited to come to us.
Okay.
When you deal with patients' lives, and there are days when I'd wake up in the past, good Lord, please help us make sure that we don't hurt anybody today.
Okay. All right. I got it. You look like you have something else you wanted to add, Benita.
Oh, yeah, I just want to say that the HMAT group that, we've been meeting like twice a week or sometimes more than that, they really have been it has been a great help sitting down with, the group that we have and just helping us analyze the amounts of data that the hospital has and, discussing all the issues and how we can go about fixing it. And otherwise, if you were going to hire a consultant to do that, you're going to be spending a couple $100,000, and with just the people that we have here, we can they can help us analyze and assess the issues that the hospital has had for many years.
Okay. So, and if I may, I just wanted to also note that these are leaders in the government, in finance and in research, and the health insurance commissioners there with us, and so there's that perspective as well. But I think for me the most gratifying part of being able to work with them is that they've also met with the hospital staff, and they've asked questions, they've asked for input, and then they've working with us to look at what is it that we think we can do to move ourselves forward. So it's not just somebody from outside coming in and saying, I have the magic bullet, but it's taking a look at the resources that we have, working with them, and then saying, collaboratively, these are initiatives that we think, stand the hospital an opportunity to move forward.
Okay. Dr. Lizama, you had?
Yeah, I just want to bring back, actually maybe in 2008, I was on the board of the Guam Memorial Hospital. And I think one of the editorial at that time was a question on, fixing the hospital problem. I did write a letter to the editor at that time and basically expressed that, I think the people of Guam needs to come together to try to figure out how to make this hospital work. I appreciate the talents, expertise of many of you up there and many in the community. I think this is a hospital that, in my opinion, can be fixed. And so in my presentation to the governor about what I want to do for the hospital, what I want to see this hospital, these are some of the people that came forward. I'll certainly invite Senator San Nicolas and anybody here that will feel that they can help the hospital. But ultimately, I really do think that even given the challenges we have with our payer mix, with a fixed subsidy, we can, move forward and not come to this legislature again and again, because we're going to have a business model that would sustain it. And, certainly I welcome great leaders out there. I mean, Senator Leon Guerrero, I respect a lot, and I listen to her views on how the hospital should be run, certainly. But that was my letter to the editor then. I maintain that position that this community can come together to help fix this hospital.
Okay, thank you. I just have one more point, and that is, I know mention has been made about cost containment, and quite frankly, you probably nickel and dime the the hospital, and to the point where the patients have to bring their own Band-Aids, and I don't know that you're going to get enough savings from all that. And I know that I stepped out while discussions were being had about the revenue centers that the hospital has divested itself. But if I may, is that feasible to restore back some of those revenue centers to increase then the income? And I know you're not going to be able to do it next week, but is that still possible? I've heard arguments that the hospital divested itself of certain of those activities because the insurance companies won't pay for it anymore. So I don't know. I mean, is that something that the hospital is going to look at to restore some of these revenue centers?
Yeah, and again, in the model of transforming the hospital from a long-stay hospitalization to a short-stay service, such as outpatient minimum invasive procedures, cardiac cath centers and the centers of excellence. Yes, I mean that would be an opportunity to bring back the revenue generating services.
Okay. All right. That's all. Thank you.
Thank you, Mr. Chair, and good afternoon. I guess just for a point of clarification, the discussion was basically that what you're presenting today, which basically amounts to an increase of 20 million from what was originally presented by the governor in January. Although there was another discussion about the vendor payables not being a part of this presentation because it's part of another presentation. Am I right? Okay. So there is that connection between the two pieces of legislation that's before this body. What if the other than this budget, what if just this passes muster, not the other one? Is there a contingency plan, or is there a plan B to be able to take care of the vendor payables moving forward?
It's going to be very challenging, Senator, because when you go back again and look at the underpayment for the hospital, the underpayment of the 3Ms and the uncompensated care, that's the reason why we're proposing that budget, because that's what the hospital needs to provide services than what we currently do. I mean, the current operation, it's very difficult when you're basically managing the cash hour by hour. How much do you have at this time? Can we buy this supply? Wait, because, we're waiting for payment and, vendors calling in, and it is very difficult. And I feel for these vendors that come see us almost on a regular basis, send us emails and text messages, and then, it's very, very difficult also on the procurement people who have to go and source, catheter, hemodialysis supplies that are needed because they have 1 day supply left, or, there's a surgery that is going to be performed the following day and we need a certain type of supply. That's the reason why we need to pay the vendors. I mean, that Senator Rodriguez has a hearing on Monday for that. But the budget that we're presenting, this is for FY17.
Right.
So this is not to pay the vendors that we already owe.
But we're not saying, though, that in the discussion of putting your FY17 budget together, that there was no consideration of how you were going to take care of your past due amounts, or was that in fact the discussion?
No.
Okay. So that said, there was. I'm just trying to wrap my head around the sequence of events as how we got to the 20 million additional. Go ahead.
Well, it's what the each department needs for the operation, and equipment, that minor equipment and that are needed that have not been provided. We have some of them are continue to request for it every year, and some of these equipment are dated and don't really function, even though we try to do a patch up work or try to modify it. Many times when we have emergency situation where we need some equipment, we go to the volunteers and ask if they can buy it for us, and that's not really how you run a hospital. Always desperately asking for someone to buy you something, when the problem with the underpayment again and the uncompensated care is I think that's a community issue, and it's not GMH. GMH should not be burdened in trying to find money for that when the staff, the nurses, the doctors spend their time trying to take care of the patients. So, they shouldn't be worrying about, do I have supply to do this? And in fact, just today on the hallway on my way here, one of the ICU doctor, can I order my supply? I need this. I said, okay, doc, go ahead and, order it, and, hopefully we'll get the money to pay for that. I mean, we have the authorization, but, the cash is a different story.
Okay, well, and the reason why again is recognizing what the budget request was. I just need to know, when did we have this discussion about, okay, we won't include in our budget what we owe to vendors, because that will be carried on by another piece of legislation that we're going to propose.
If we were to consider that, then we'll add $30 million to the budget. So
yeah, then we can go into the discussion of the priorities.
So you can add it to 170.
Yeah.
Right?
Well, if you
and ironically, it's the
1 plus 1
the
is
funding
2.
for the hospital.
And so, if you add the two different bills together, but I'm just trying to find out when this discussion occurred. Okay, so that I'm going to be quite honest. We're going to be hard pressed to be able to find, the funding, and we have to be resourceful and and in the case of what my party here, Dr. Larry says, innovative and really wrap our heads around as a community.
And Senator, that's one of the reasons why we look at the payer mix, and if we're having difficulties in pushing the TEFRA rebasing, when you look at how we're reimbursed between the inpatient and the outpatient, we get a significantly higher reimbursement for the outpatient. So for those patients that can be treated in an outpatient basis, the plan is to shift that to the outpatient setting so we can get, a significantly higher reimbursement. And that is also evident in how when we analyze our collections from the 3Ms and look at how much do we get from inpatient, how much do we get from outpatient, there is a difference. So that's the mindset is to try to shift whatever services we can shift to the outpatient services.
Okay. Thank you, Mr. Chair.
Could that outpatient service be provided in the urgent care?
Maybe. Well, that's radiology, that's cath lab. So it's probably not going to work in the urgent care setting.
In the hospital setting, Vice Speaker, we're looking really at outpatient service as a 2 midnight rule. Medicare as classified patients that stay at in the hospital setting under 2 midnights as outpatient. So we're really going after that market of, again, providing greater efficiency in delivering care and greater results, hopefully, and at the same time recovering more revenue, because now we're basically will be paid under an outpatient reimbursement fee.
But that can't be provided in the current rooms that are in urgent care?
Well, some of those are procedural, such as interventional radiology. So you would need to have an observation area. The idea is to have an observation area for patients to, get their procedure, be watched hopefully, again, be discharged within 2 days.
Mr. Speaker, if I may ask for clarification, are you looking at the space where the urgent care is currently?
Well, I mean, it's only used 12 hours of the day, so I'm trying to figure out, could some of that work be done there and release them?
Yeah.
Yes, of course.
sir.
And we're not going to realize the new wing if we get, the new wing. So, and my oncology program is going to start next month. So we're going to start giving chemotherapy in the hospital. So we're going to be utilizing every space we have. And so during the downtime of urgent care, we'll be utilizing urgent care.
Yeah. We actually had that discussion with Dr. Lizama about the utilization of the space in urgent care. So, in line, I think, with what you're trying
Yeah,
to
I mean, it just seemed to me.
verify.
And Senator Frank asked a good question that was my first question that I should have asked about the subsidy. How much of the 21 million that we authorized, because you said the authorization's there, but the cash is different. How much of the authorized and appropriated 21 million from last year's subsidy have you received?
From last year?
From this current year?
Hang on, I need to look at, I think I have received what I'm supposed to receive to date.
With 3 months left, does that mean a third still hasn't been received? Because
I believe I have received the allotments, all the allotments.
You mean the
But
full
I think-
21 million?
Yeah, hang on, Senator, I need to look at my detail here.
In response to Senator Frank, you were the one that said there's a difference between the amount authorized and the cash received. So.
Well, when you're thinking about the budget, the authorized budget was 132.
No, but I mean,
Yeah, we don't necessarily tie it to the subsidy.
No,
It's,
but the subsidy. Yeah. I'm just asking about the subsidy.
yes, as of May, the May report, we have received about $8.8. I mean, let me. I need June to clarify this because this report was just given to me.
The subsidy is 21.
Yes.
We're in the end of the third
understand.
quarter to just about.
The 15 is matching.
Yeah, you cannot count the matching because that we consider that under the Medicaid MIP. That's our
How much of the
operating-
pharmaceutical have you received?
Yeah, it's 1 million. It's 1.9.
We budgeted 15 million from the pharmaceutical fund. You've only received one?
No. That's the direct subsidy. You have to, the direct subsidy is different than the 75% because that goes under Medicaid and MIP, and we don't recognize that as a subsidy because that is payment for services for Medicaid and MIP.
All right. From the Healthy Futures Fund, how much of the Healthy Futures Fund have you received?
1 million.
That's the 1 million we used to pay the loan.
We appropriated, or at least I thought that we appropriated 6.367.
I mean, this report is May, but we receive a significant amount in June, so I don't have that number.
Significant, please.
No, I can give you. I
I understand, Benita. I'm just saying.
Yeah.
We were here for a budget hearing, okay? And it would seem to me that and it was my first question that I should have asked, and I'm derelict in not following what my staff told me. The first question that I should have asked, since you were asking for 45 for next year, how much of the 21 have you received? Because for DOE, we know that we appropriated 225 for them, and to date they've received 160. So I'm trying to figure out, are you in the same position that DOE or university or GCC is? Because it seems to me we've tried to appropriate for you and be honest, all right? You're under oath.
We received, that's what I said, we received a significant amount in June. I haven't received that breakdown, but according to what, because I was asking June for the financials for June, but, he told me that we had received the entire amount already in June because, we did the check exchange.
Okay. The check exchange, that would have been for the reimbursement for the 3Ms. Would that have been the amount that would have been used to match from the pharmaceuticals?
You have the detail.
No, Senator, this is the exchange that happened between DOA and the hospital.
No, I
The
know
other
what exchange, yes. The paper exchange of $13 million to cover
So
withholding tax.
They gave us all our allotment for this year to pay for that income tax. You see the picture?
No, because
We need-
the amount of money that's owed to you from the 2Ms or the 3Ms or whichever it is different from the subsidy that we were supposed to provide for you. Have you received an amount equal to the $21,700,000 that we provided?
Yes, as we speak, they're still paying us Medicaid money. The year's not over yet, so there's still some money on that matching. However, all the allotment for our use has been given to us this month. Everything.
And how much is still outstanding? Was there a reserve?
There's no reserve. There was no reserve.
And so, have you received 3/4 of the amount?
100%, 1 year.
Okay. Please, go ahead.
Okay, I just want to follow up on something that you're making available. So the pharmaceutical fund that's supposed to go directly to GMH, you guys are passing that through Medicaid?
it's the legislature passed that to use it as matching for Medicaid. So we don't consider that a direct subsidy because it is for services that the hospital provides, and it's to match the local match with the federal. Then that's how we get paid.
So Medicaid is using your money to pay you.
No.
Maybe yes.
When the oversight chair decided to increase the amount that we were going to get from pharmaceuticals, it was with the intent that we would take that $15 million, and that would be the 45% match that the government would have to get the 55% match from Medicare. So rather than give them $16 million straight, we funneled it through Public Health and Social Services so that we could get them
The payment.
38.
But you're still
Rather
only getting
than
your billings
16.
honored at 44%.
Because that's how the hospital has been reimbursed. That's just you don't get, if you bill 100,000, you don't get everything back because it's per
But if you
diem
got
basis.
100% of your pharmaceutical fund directly to you, you still would have gotten that billing from Medicaid from a different source.
If that was going to be a direct subsidy, then the hospital would get the whole amount, and then we'll bill Medicaid, and that would be another collection.
No, the intent was
Yes, I understand. Yeah.
to try to maximize the dollars by using it as matching.
Yeah. But how we book it is we book it as operating income, because that's for the services. It's payment for services at the hospital.
And Is skilled nursing a moneymaker for the hospital, or is that a...
Hang on. Well, our operating budget for that, I mean, the expenditure on that one is about $3 million, and then our revenue is about $6, but that doesn't necessarily mean we collect on the $6, because again, that's the gross amount.
No, I'm just asking, because in our discussions yesterday, you talked about moving skilled nursing from Barrigada Heights to the campus.
Yes.
And I'm trying to figure out, as long as if it's making you additional money, I hope it's not another cash cow that you're going to give away to somebody.
Yeah, Senator, I'm glad that you brought that about SNU, because, maybe not very many know, and not the community know that, the last I heard, we had like 8 social cases where these people don't have any place to go. I mean, we can't release them to the streets, so they are at SNU that the hospital is treating, and the hospital continues to be burdened with that. That's 8 patients.
Okay.
So that's one of the reasons why the hospital needs to be funded.
You're good at that. Okay. Anyway, I don't know if there are any nurses here from labor and delivery, but I want to... This hearing was not as contentious as everybody thought it was going to be, because thankfully those of you in labor and delivery were able to provide for me this year 2 little grandnieces who have brought... And I really want to commend the nurses in the labor and delivery. Fortunately, I have not been anywhere else, but at least what I've seen in the 2 occasions that I've been there was phenomenal professional service. And that was by the nurses. I mean, the way that they handled everything, there was an emergency, and it was, I thought we had lost. But thankfully, all of you had your wits about you, had the surgeon brought in and the anesthesiologist, and so I just want to thank all of you publicly for the excellent service that you provide, and I don't doubt that it exists throughout the hospital. Yes. Benita knows I'm happy with the professional staff. It's just her billable section is the one that is driving me crazy. Yeah. And so if they could just bill and collect for all your excellent service, we'd be all right. And maybe they're the ones that need to go to ICU.
Senator.
Mr. Speaker, and if I may just echo the sentiments that you just expressed about, the level of care that you saw in the labor and delivery room. And as you said, you are sure that it exists throughout the hospital, and I would like to say that I agree with you that it does exist throughout the hospital, and that's why the staff work really hard, on a daily basis, because we want to change the public's perception of get me to Hawaii, and we've actually even heard get murdered here, to great medicine here, to stand for GMH.
And I really do appreciate the service that you provide. I mean, I've had a number of friends that have successfully come out of the ICU. Some of them several times. And so, but we've just got to figure out this billing system, because they're doing excellent work and we're not collecting it. And we're going to have to work on it, all right? So,
of course.
Thank you again to all the professional staff at the hospital that do their work on a daily basis, and the doctors. And let's just hope that we can get people who understand hospital and medicine to take over our finances. Thank you. We stand in recess until 10 o'clock on Tuesday morning when I hear from Department of Public Works.
Thank you, Senator.